and welcome to Insights on Prostate Cancer with Professor Ann Hamilton of the University of Southern California Health Campus Keck School of Medicine. Dr. Hamilton is going a little different direction than we usually go. We usually are treatment providers. Tonight, what we're going to look at is something that Dr. Metzger talks a lot about in his newsletters, which is long-term studies. And what long-term studies mean ultimately to the kinds of decisions you make and how happy you're going to be with those decisions based upon patients that have come before you and shared similar challenges. So we're going to have insights into prostate cancer survivors provided through participation in population-based research studies. About our presenter tonight, Dr. Hamilton brings close to 40 years of experience in research in not only prostate cancer, but other kinds of cancers, including breast cancer. I urge you, if you can, Google her background at USC and Keck. Here's a little bit how we run our meetings. Our experts present for approximately 40 minutes, give or take. Could be longer, could be less. During and after the presentation, you may enter questions via the Zoom chat box. I see those, and others see those, and I will read them to our presenter at the end of the presentation. And we may bring you in and ask you to unmute your mic so we can ask you to clarify a question or elaborate on a question. In the meantime, please stay muted. And without further ado, I'd like to introduce Professor Ann Hamilton of the USC Keck Medical Center.
Well, thank you very much, and thank you very much for inviting me to speak at your group. As Neil indicates, I've been at USC for many years, but I really got my start in terms of studying prostate cancer back in 93, 94, when a study called the Prostate Cancer Outcomes study was initiated by the National Cancer Institute at the time when PSA screening was first introduced. And since then, there have been other studies following the CEASAR study, which I think Dr. Metzger noticed an article about, and probably that's where he got my name, to reach out to me about talking about it. So I hope this will be of interest to you. And like Neil indicates, it's not a study about treatment. It's more sort of how you can be altruistic in a way in terms of providing information about your own experiences with prostate cancer that might help others in the future. Yeah, so I've titled this Insights that Prostate Cancer Survivors Have Provided through Participation in Population-Based Research Studies, making it a bit broader than just one study. And this is my email. If anybody has a question later, please feel free to contact me about it. So briefly, I'm going to just briefly talk a little bit about prostate cancer statistics, incidence, survival, mortality, and some trends in these numbers. Of course, I think you all are aware of the importance of screening and how this impacts rates of prostate cancer. Screening is kind of a double-edged sword, as you know. We want to identify cancer early. On the other hand, regulations and recommendations about screening have changed because of the fear of overtreatment. And that's because there are long-term side effects of the different treatments on sexual, urinary, and bowel functions. And these studies have tried to quantify the extent of these functional impairments that might occur as a result of treatment. And as we indicated, this research is important for treatment decision-making for men in the future. And also maybe for some of you who are at different time points since you've been diagnosed, you might be interested in experience over 15 years since diagnosis from other men to see how trends have changed or how functional impairment has improved or possibly gotten worse. And population-based research is important. And by that, I mean, cancer cases are reported to cancer registries in all states. So it's a law that cancer be reported to registries. Therefore, we get, and this is how quality of registries is determined. And in the United States, our cancer registries are quite good. We get practically 100% of all cases that occur reported to the registry. Hospitals are required to report them. If somebody isn't going to the hospital, it's reported by a path lab or a medical doctor's office. And then we can link the incidence or the numerator to the denominator. In other words, what is the population at risk in that defined geographic area, like Los Angeles County, for instance. So we would have all the cases and we could calculate rates then of cancer. Another benefit of cancer registries is that linkages can be made to other population-based resources like vital statistics, so that people with incident cancer can be compared to subsequent mortality and be able to come up with death rates, mortality rates as well, that are population-based. And so there are two main studies that I'm going to discuss a bit here. The PCOS, or the Prostate Cancer Outcomes study, the one I first mentioned that I participated in, and then the CEASAR study, which has been recently published and just completing 10 years of follow-up. So about 12.9% of men will be diagnosed with prostate cancer at some time in their lifetime. These percentages are fairly constant. This is based on 2017 to 2019 data. However, as you can see, there are 3.4 million men living with prostate cancer in the United States. So understanding how prostate cancer impacts quality of life, functional status, health, mental well-being, and other factors that affect happiness and other issues in life are very important for a large number of men in our country. Well, just briefly, you can see that prostate cancer is the top cancer diagnosed among men in our country, 110 per 100,000. And this source I obtained from CDC, the Centers for Disease Control, and it applies to the next several slides that I am showing. You see lung cancer is second, followed by colorectal cancer, and these other cancers, as you can see on this slide. However, mortality is much less for prostate cancer than for lung cancer. So about 18.8 men per 100,000 will die of prostate cancer. You can see this is quite a bit lower than the incidence. Mortality, fortunately, is a lot lower, whereas with lung cancer, mortality is a lot higher. And the 5-year relative survival for prostate cancer is the highest among all these cancers for men here, 96.3, followed by testis cancer, thyroid cancer, melanomas of the skin. Fortunately, those that can be diagnosed that have not yet become invasive. Regarding the stage distribution of prostate cancer, 70% are diagnosed at localized stage, meaning the cancer is not spread, 13% at a regional stage, just spread directly to nearby lymph nodes, tissues, or organs, but not distant metastases, which account for about 8% of cases. But survival is quite high for both local and regional cancer, but lower, as you can see, for distant cancer. These unstaged cancers, obviously, a lot of them are likely to be localized or regional, given the high survival rate that we have here. These are annual rates of new cancers of prostate since 1999. You can see the numbers have gone down here, and this is because we have changed the recommendations for screening, especially here 2010, 2012. Screening has not been recommended. However, there has been some uptick here, as there have been some modifications for recommendation of screening in high-risk groups. And these would be particularly those who have a family history of prostate cancer, African-American men in particular, so that, you know, it's not a hard and fast rule about screening. This is why these decisions are always recommended to be made with your doctor, making a shared decision about screening. And this sort of lower dot here for 2020, as you know, we had the pandemic, and a lot of men were not screened. A lot of men did not go to the doctor due to that those restrictions. And so the number of cases in 2020 across the board for a lot of cancers is low. And this is just kind of a little bit more of a historical trend back to 1975. This shows a huge peak we had like here in 91, 93, which, as I mentioned, initiated the Prostate Cancer Outcomes study with the, on use of PSA screening. And this trend here, though, for Blacks has persisted. This is one of the largest disparities there is in cancer. And I'll talk a little bit more about that. These are incidence rates, just by race, ethnicity, a little bit more detailed, going back a little. This slide only goes to 2012, but you can see the rates for Black men, again, much higher. And we have this green line is all races. Whites are a little bit lower than that. Hispanics are lower, and then Asians and Pacific Islanders, Alaska natives are down here showing the lowest rates. And this is mortality. it has declined. However, it has leveled off. And I think there is a bit of worry that with the change in screening, there may be more later stage cancers not being detected early, and there's some concern about in recent years if this line is going to tick up again with mortality. There are more cases being diagnosed in the US, and that's due to the aging of the population, us baby boomers. And then this is mortality trends historically. Again, you can see the much higher rates for African American men in the red line. So I'm talking a bit about some of these completed research studies. PCOS, I mentioned this, was initiated due to the spike in prostate cancer incidence in the mid-90s. And these men were followed for 15 years with multiple surveys and medical record review. And they were selected from 7 cancer registries around the country, including Los Angeles. And my role in all these studies was to be the subcontract principal investigator for the Los Angeles fieldwork effort. And then, of course, to participate in the analysis of all of the cases combined. And long-term outcomes were reported in an article in the New England Journal of Medicine. I'm going to just show you some of the results from that in comparison to the CEASAR study, which was initiated actually by one of the investigators from the PCOS study, David Penson, a urologist, initiated the CEASAR study to assess newer treatments in a second prostate cohort, because people recognize that since 93, 94, now we had robotic prostatectomies and other advances. And so the long-term follow-up impact of treatment might have improved with more recently diagnosed cases. And then this study has been continued by Dan Barocas. He's another urologist from Vanderbilt, has been the main principal investigator over the remaining years of the CEASAR study. And a lot of the work on the analysis, especially in this paper in JAMA, has been done under his leadership at Vanderbilt. And these cases were selected from 5 cancer registries across the country. Then there are some other studies that don't involve patient contact. CDC had a study that I was also involved in called the Breast and Prostate Patterns of Care study. This involved abstracting of medical records to assess treatment men received, and then later on linking them to mortality data. Then there are a couple of new studies. Another one I'm involved with is called the PC Concept Study. This is led by a urologist from Weill Cornell in New York. This is to assess the impact of focal therapy and partial gland ablation, cryotherapy on outcomes, and then compare those results to standard treatments like prostatectomy, radiation therapy, active surveillance as well. And then I'll just mention RESPOND. This is a different type of study. It's not designed to assess the effects of treatment in the same way that these previous studies were planned. This is a study specifically of African American men with prostate cancer in the US involved men from registries in 8 states to investigate why African American men have the much higher incidence and mortality from prostate cancer compared to white men. And I'm very proud of the role I played in this study. It was led by cancer genetic epidemiologist Chris Hyman at USC. And based on my experience with a lot of these other studies and connections with the other registries around the country, I led the recruitment effort for this study, and we have recruited 12,500 men, which is a very large sample size and certainly the largest sample of African American men with prostate cancer that it's ever been collected. And in addition, we have gotten saliva samples to look at germline DNA and tissue samples to look at tissue somatic factors. So this will be an all-encompassing analysis to look at self-reported information as well as genetic information. A lot of the survey included information on social stress, racial discrimination, and other issues that might have increased the risk for African American men. So I thought I would go through the prostate cancer outcome study methods just a bit. It's very similar to what was done for CEASAR. CEASAR kind of followed the same model. Again, we are trying to assess variations in diagnosis and treatment of prostate cancer, and then assess health-related quality of life among survivors on these specific domains: urinary, bowel, and sexual function, as well as overall effect on health. One thing I really want to emphasize on these studies, because I have to say, quite frankly, some men who are contacted to participate in studies like this are very surprised that we're able to contact them. How did we get their name? That they have prostate cancer. Well, as I indicated, prostate cancer, all cancers are reported by law to the cancer registries. However, in order to contact somebody, first of all, you have to get grant funding, which involves peer review, a lot of scrutiny. Grants are very hard to get these days, so I think that they really have to be excellent to get funding. And then there's IRB, the Institutional Review Board approval, both at USC or the particular institution an investigator is from. And in California, there's the California State IRB that's called the Committee for the Protection of Human Subjects. And all of the mechanisms of contact, the letters to be sent, an information sheet that describes everything involved in the study is carefully reviewed, and it is ensured that subjects can make an informed consent to participate. And especially important is the mechanism that investigators take to assure that the data would be kept confidential. And then in the end, the California Cancer Registry approves the release of the data for these studies. And so a person can be contacted, they can decline, that's fine. No information about that person is ever released. No information about cancer, anything like that is included in the exterior of any envelope or letter mailed to a house inviting somebody to participate. So we do try very hard to make sure that this is not something that is upsetting to somebody to be asked to participate in a study. I would say 95% are, understand the purpose of research and are willing to participate. However, there are some people who are upset about it. And I just mentioning to you as cancer survivors, if you should be approached to participate in a study, I just like to let you know what's involved before anybody can be contacted about a study. So from the prostate cancer outcomes study, we selected cases with primary prostate cancer, meaning the first incidence of their cancer, diagnosed in 94-95. Rapid case ascertainment, CEASAR is the name of the National Cancer Institute's cancer registry system. And it stands for Surveillance, Epidemiology, and End Results. It's kind of an odd name, and it's probably not the best name currently, but that was what it was originally called. And the normal procedure for reporting cancer is that hospitals are required to report it at 6 months after diagnosis to the cancer registry. However, for some studies, it may be more important to reach a person sooner than that. So there is a system called rapid case ascertainment where cases for a particular cancer can be selected a bit earlier to be able to contact the person closer to the time of diagnosis. So the sampling oversampled Blacks, Hispanics, and men diagnosed under 60. And then men were sent questionnaires through the mail at 6, 12, 24, 60, and this was an old slide, obviously, and then at 15 years after diagnosis as well. And then the protocol is essentially to mail the questionnaire, then follow up with phone calls to increase response and include interviewers who can speak Spanish, especially in Los Angeles area. And then at 5 years, men completed forms listing where they had received care, signed consent forms to obtain medical records of HIPAA forms and tissue blocks. So for this study, about 3,500 men participated. That was 62% of the sampled patients. And we were able to obtain medical records for 99% of those for treatment during the first 12 months. Then by 5 years, 65% of them participated again. And then by 15 years, I'll have to look at the numbers, but it keeps getting lower and lower. And that's going to be the last PCOS questionnaire.
Go to your poop. Go to your pee. Go, good boy.
Pardon? I'm not sure if that was a question for me or not. And so what do we ask on these questionnaires? Well, demographic information, symptoms, self-reported information on therapy, disease status, or have they had any indication of progression, comorbidities, then the functional status questions, which are what I'm going to go into more detail on the urinary, bowel, and sexual function, and then general health information. This is called SF36, or the short form 36, but then there's even a shorter form 12 available. All of these questions have been developed by psychologists. They've been, in other words, you don't just create your own questions for conducting this research. You have to use questions that have been historically validated. And this is a standard one to obtain general health information. Then there's also questions on their satisfaction with care and treatment. And so the questionnaire that used to obtain functional status is called the EPIC, or the Expanded Prostate Index Composite. And this is the same question that was used for the CEASAR study as well. So for each domain, which is a bowel, urinary, and sexual function, each one is called a domain. There are 4 to 5 questions asked that assess function, and 1 question assessed bother. And this is an important distinction, because a person can say, you know, they had a problem with urinary incontinence or something like this, but then they learn to cope with it, use pads or whatever, and in the end, after a while, maybe the bother wasn't as large, or maybe it persisted and it was a lot of bother. So in other words, function is one thing, but how much it bothered the person is another aspect that's being measured. And so function at each time point was assessed, as well as baseline levels. Because as you can understand, people start out differently when they are diagnosed with prostate cancer. Somebody who's older may have lower function in some of these areas at the time they're diagnosed than, say, a younger man or a healthier man. So it's important to understand how change from baseline for each particular person has occurred. And so this was just an example of what a function question, like for urinary function. Over the past month, which of the following best describes your urinary control? Total control, occasional leaking, frequent leaking, and no control. And then this is the bother question. How big a problem did you have with leaking or dripping urine? No problem, very small, small, moderate, or big. And sometimes I think they, like in CEASAR, I think they dichotomized no problem to small problem versus moderate or big. So then a function score is created for each domain based on the 4 to 5 questions. And so they are calculated to equal 100 points for the best functional status. And so then these scores were calculated for each domain at each time point. And then statistically, they've been adjusted for confounding factors, other factors that could also affect functional status: age, race, clinical stage, education, income, comorbidities are some that have been adjusted for, some variables. So back at the time of PCOS in the mid-90s, this is the distribution of treatments that men received. Some of it is similar today, except back then it was called watchful waiting. Now it's a different type of reason for not being treated. Watchful waiting back then was more palliative for men who were not really in good enough shape, perhaps, or had shorter life expectancy to receive these more active treatments of radical prostatectomy or X-ray therapy. Now, active surveillance is considered a curative management strategy for men with lower risk who may later receive active therapy. So it has a different connotation than watchful waiting did back then. And as you can see, watchful waiting here was much higher among the older men, whereas now you see more in these other age groups. I think, however, the use of radical prostatectomy is also lower among older men who then would instead have radiation therapy. This just is to demonstrate the difference in baseline scores for these three functional groups based on treatment. So for sexual function, you can see that the highest scores were for men who received a radical prostatectomy, and lowest here for those who just received hormones or watchful waiting, and sort of in the middle here for X-ray therapy. And that's because these men getting prostatectomies are the healthiest, youngest men, so they have higher scores. Of course, there's hardly any difference in any group for bowel function, and this is at baseline. And then for urinary function, again, those men getting prostatectomies had the highest scores, but there was not as much drop off in these other groups as there was for sexual function. And then we looked at how the scores changed from baseline. So baseline is 0 here. And then this is what happened at 6 months, how much the scores dropped. So you can see that for prostatectomy, they had, this is urinary function, the largest drop in their scores at 6 months compared to the other therapies. However, as time went by up to 5 years, you could see there's improvement, but they never quite got back to baseline. Whereas the other treatments did not lose so much function over time. I think this issue of urinary function impact of prostatectomy has also been shown in other studies. And then this is the bother question. Again, as I mentioned, there seems to be adjustment. With radical prostatectomy, a lot of bother at 6 months. However, by 5 years, not so much. Everybody, regardless of their treatment, is coming together. This is bowel function scores. You can see X-ray therapy had the largest drop here, the green lines, but it gradually improved over time. And then also higher bother for X-ray and other in particular at 6 months, but then by 5 years, the amount of bother expressed had declined. Sexual function, here this is 0, is baseline. All groups declined, especially prostatectomy, some recovery. But even watchful waiting, older men after 5 years, there was decline, so that different treatment groups came together a lot closer by 5 years than at 6 months. And then this was percent. I missed the top of that slide. Problem due to sexual function, high at 6 months, again declining. You know, the amount of bother declining by 5 years. So I was just going to briefly show you some of the PCOS results at 15 years. And the bottom line was, at 15 years, no significant relative differences in disease-specific functional outcomes were observed among men undergoing prostatectomy or radiotherapy. However, men treated for localized prostate cancer commonly had declines in all functional domains during 15 years of follow-up. So I have I wanted to show you some data from that New England Journal, and I have it here to show you. I just have to flip it around here. Unfortunately, in this journal, they put it in sideways. Well, that didn't help. One more. Okay. All right. So here we see, this is PCOS. This is urinary function in all patients. And this is 15 years. You can see radiotherapy versus prostatectomy. So this shows the decline in the score. Before I showed you the change in the score, this shows the actual decline in the score. You can see there's a bigger change, their drop here, and less change in radiotherapy, and then some increase, but still, even though prostatectomy had lower urinary function at 15 years, it was actually not statistically significantly different. You can see these kind of, the tan bar and the blue bar, essentially confidence intervals. And so they overlap, but nevertheless, those with prostatectomy had lower function. And then they just dichotomized between normal urinary function at baseline, show it's a similar trend, and then those men who actually had lower urinary function at baseline still continue to have lower urinary function than those with radiotherapy, but again, it was not statistically significantly different. You can see, however, here, earlier at 5, we didn't do a 10-year study for PCOS, just 5 years and then 15 years. you could see at 5 years, there was a lower function for prostatectomy. But by 15 years, it was no longer statistically significant. And then oops, I'm trying to, okay, good. Here we have sexual function from PCOS. So here you can see sexual function change, prostatectomy versus radiotherapy. Although there's declines over this time, there's actually no difference here at 15 years, regardless of whether a person had higher sexual function at baseline or lower sexual function at baseline. They all are coming together here at 15 years. I think, as you'll see, this is the same conclusion from the CEASAR study, that there is no significant difference over time here for sexual function. And then finally here, bowel function. Here we see radiotherapy having lower function over time compared to prostatectomy. And this is similar if the person had normal bowel function at baseline or lower bowel function at baseline. Again, however, although they said no significant difference, it does seem that there may be a bit of difference here for radiotherapy, continue to be a bit lower after 15 years. So I wanted to also show you the questionnaire used. I wanted to now go to the CEASAR study and give you some idea about the types of surveys that are used to collect the data. I don't want to go through this in too much detail, but to kind of give you some idea of the types of questions men are asked that then are used to provide the information. So this is a CEASAR study. As you know, CEASAR, this is not how you spell CEASAR, like for Julius Caesar. It stands for Comparative Effective Analysis of Surgery and Radiation for Localized Prostate Cancer. But it also included active surveillance, not just surgery and radiation. But so this logo kind of looks more Julius Caesar-like, but and many people would say, oh, you're spelling Caesar wrong. At any rate, that was why we came up with the name. These are questionnaires to be filled out at home or whenever a person felt like it. And it's not like being in a doctor's office or anything like that. It's mailed to the man. They can throw it in the trash or whatever. They can choose to participate. And it mainly takes up time, essentially, is the, you know, the cost of doing it. So we ask about follow-up care, what their last PSA values were. Did they report any recurrence? And did they feel that their prostate cancer is cured or not? And then if not, what are the reasons why not? They had elevated PSA or other metastases to lymph nodes or bones or other areas. We asked them to report the treatments they've received. And other indications about medical care. Did they receive medications to strengthen bones? Treat medications for anxiety or depression? Have you seen a mental health specialist? Received testosterone supplementation? And what was their expectations of the treatment, and compared to what they expected, how did they rate what they received? And these are general health questions, because many things about a person's general health can also affect their cancer survivorship. So these are comorbidities, problems breathing. Did you have, flu or other respiratory problems, shortness of breath, heart attack, high blood pressure, these types of questions. So this is quite extensive, I know. Diabetes. Then these are activities of daily living. These are standard questions. And actually, this one question, how would you rate your health? Excellent, very good, fair, or poor, is one of the best predictors of outcome. So these are, I mentioned those SF-36 questions. These are the questions that go into that relate to physical and mental health. Like, can you do moderate activities, climb flights of stairs, these types of things? Do you have any issues with mobility, self-care, usual activities, anxiety and depression? You could put a number on this scale as to how you would rate your health today. This is more mood, mental health. And now we get to the epic questions, the urinary questions. And these are the functional ones: leaking urine, no control, using pads, and then how big a problem, and bowel issues. How big a problem have your bowel issues been? Sexual function. We ask about assistance to assist with erectile dysfunction. Many questions here about sexual function. And then these are the hormone-related questions, hot flashes, and so on. And these are more mental health questions. And these are some more specific questions related to long-term problems. And then how much of a burden overall is prostate cancer for you and your family? Cause financial problems? How you cope with financial issues? And worry about recurrence? PSA, outlook, social support, satisfaction with care, and then finally demographic questions about employment, marital status, insurance coverage, weight, smoking. And we usually would pay $20 or $30 incentive for this, for a person to complete the study. Okay, now looking at well, I skipped over this slide. I just wanted to mention that there are many, many papers that have been published from the PCOS study. These are just two. This one indicated that major comorbidities predicted lower survival and should be taken into account when making a treatment decision. And this study was one that has followed, there's, we don't have clinical trials, and there's, a lot of feeling that radiation therapy and prostatectomy may have no difference in survival. However, over the long term, 15 years from PCOS, we did see a survival advantage associated with RP versus EBRT. But it's qualified. There could be selection bias, or there could be a true survival advantage. I think this is something that, is looked at more and more carefully. I mean, if a person's going to survive 15 years, a younger man, long-term survival could definitely be a benefit having prostatectomy versus radiation therapy. Okay, the CEASAR results at 10 years. We already looked at the survey there. In terms of how they analyzed the data, they did it a little bit differently than for PCOS. They have two groups here, the favorable prognosis group and the unfavorable prognosis group. The difference here is this is mainly T1 and T2B and PSA lower than 20. Whereas the unfavorable group had T2C and higher PSA and higher grade group. Now, just so you know, the grade group is a term used these days instead of Gleason score, but it's based on Gleason score. Grade group 1 is Gleason score 6 or lower. Grade group 2 distinguishes differences for the Gleason score of 7, 3 plus 4. This is the first one is the more predominant pattern, followed by 4. Whereas if 4 is the more predominant pattern, it's a more serious type of a 7. And so the less favorable prognosis group has 3 through 5 versus 1 through 2. They found in the end that prostatectomy was associated with worse urinary incontinence, but not worse sexual function compared to those receiving active surveillance or EBRT. In the unfavorable prognosis group, prostatectomy was also associated with worse urinary incontinence than those with EBRT or ADT. However, radiation plus androgen deprivation therapy was associated with worse bowel and hormone function compared to those receiving RP. And I just had a couple of more reviews of that JAMA paper. There is a tremendous amount of information in this paper. They have really looked at this very carefully. And so this is similar to those graphs I showed you for the PCOS study. This is for sexual function, urinary continence and irritation, bowel function, and hormone function in the favorable prognosis group. So sexual function, you can see here at 12 months, there was a decline. The orange line here is the RP group, but then there was recovery. And by 10 years, very little difference. So, I mean, I think some of the important things to think about is that during this earlier time in this survivorship period, there could be differences with these therapies, but by 10 years, these functional status questions have come together pretty much regardless of therapy received. However, for urinary incontinence, they continue to see that RP had poorer outcomes. However, by 15 years, according to the PCOS paper, these still continue to come together. And then there was little difference here with urinary irritation or bowel function by treatment group or hormone function. That was in the favorable group. And then in the unfavorable group, you can see their sexual function did not decline as much. This is just rating RP versus EBRT plus ADT. However, they did continue to see the lower urinary incontinence scores for RP, same as with the favorable group. But no difference here with urinary irritation or bowel function or hormone function. So, just in conclusion, I'd just like to say that I've tried to show to you how patient input is critical to evaluating the impact of prostate cancer treatments for both physicians and patients. I think you can't just rely on the physician's point of view. You have to know from the man himself how these treatments have impacted him. And newer cohorts will be helpful to continually assess newer treatments being developed. The PC concept study, for one, is one that's trying to look at focal therapy. And then we did see the issue with urinary issues for RP, especially in the CEASAR study. But PCOS, even though it's based on an earlier cohort, has shown the possibility of a longer-term survival advantage for RP. And at 15 years, these differences between the therapies were minimized in PCOS. So those are some of the things to consider. I don't know if you have questions. I'm happy to try to address them.
Thank you, Professor, very much for your presentation. Let me hold on
Neil?
just a minute. Hi there. Hi, Dr.
Hi,
Metzger.
hi, I'm sorry I couldn't get in earlier, but thank you so much for that. We have never had anyone talk the real stuff. We hear stuff from oncologists and radiation guys and us surgeons, and it's good to hear it coming from someone that doesn't, that knows the truth. I've got a couple of questions I'd like to ask. Is number one, the one of the reasons some of the early stuff is different is because so many of us in private practice were operating on 3+3s that didn't need it, and of course they did well. And I think some of that has to be taken into account since active surveillance is kind of taking care of that. I think that we're getting some what is to me is more valid data. And then I wonder what PSMA is going to do to all of this historic stuff, because as we know, PSA has radically changed everything, and I'll bet that if we somehow go back in time and look at some of these things, the data would look different. I don't know if it'd be better, worse, or what it would be, but we're in an extraordinary time with PSMA and PSMA guided treatments that I just wonder what effect that's going to have. But just wonderful remarks, and I so appreciate your writing that article so I could find your name. This was great.
Well, I was not the first author on the article, but
No, but I recognized your name.
Any rate, I agree that you're not necessarily comparing apples to apples with these different cohorts. One thing they have tried to do is control for some of these variables like PSA, although I realize PSA can be measured differently at this time. But risk group, Gleason score, all of these are clinical factors that are able to be included in models. So, and one can also stratify results to look at, I mean, they've tried to do that by the JAMA article, looking at those with favorable and unfavorable prognosis to, try to make the comparisons, as best they can. However, I am struck by some of the similarities between the PCOS study and the CEASAR study in terms of the urinary issues with RP.
Yeah, I think if you broke that into university versus private practice, it would be even more striking. What do you think about the English study of 19,000 men where a group of them waited 5 years to decide what to do and nothing happened? That their data, the difference in incontinence at 15 years wasn't much difference between whether you did nothing or whether you had surgery or whether you had radiation. So
yeah, I know. Well, in these studies here, we do have the active surveillance group as a comparison. Although, as they indicated, they did some sensitivity analyses with CEASAR, because with active surveillance, several men may go on to subsequent active treatment. But they did try to make also a better comparison with those men who did not have any further treatment as well.
Well, it's interesting that the active surveillance guys, if it's guided by MRI or the new micro ultrasound, it's interesting. They're not the very few that break through. The ones that break through tend to be the misread MRIs or the misread pathology, or the guys that just didn't have targeted biopsies and something else was growing somewhere else in the prostate. There's going to be more people drop out of AS, but if you keep the criteria very stringent, and have second opinions on your scans and your pathology, I think it's a very clean way to go, and I'm so happy that some of the data supports it.
Yeah, I think that the MRI biopsy is very critical. I think African American men in particular, I know they talk about the apex or or whatever, having, to know that you really don't have aggressive disease anywhere else in the prostate. I think that's really critical.
Very much so. And again, thank you so much for spending your time with us. This was great.
Well, thank you, Professor. Were there any surprises in this? You've asked a lot of questions
Just eat that.
that are quality of life questions. And, I wanted to kind of get back to how did they analyze? Well, we're going to look at urinary leakage and depression. We're going to look at ADTs and mood swings and things like that. Were there any surprises that came out of this?
Well, I think you really, when you saw all the variables, I hope I didn't bore you with going through that entire questionnaire, but when you see all the variables that are being asked, there is a lot more analyses that can be done. And I know with PCOS, there was, and I think that this is some of the issue with active surveillance. Men are worried about subsequent disease. It's hard to say you have cancer and I'm not treating it. On the other hand, you don't want to suffer the side effects from treatment. So, but there is worry and concern, I think, among those men on active surveillance. And back in the day of the PCOS study with watchful waiting and use of hormone therapy, those men were the least satisfied and most depressed.
So they were actually on active surveillance and yet receiving hormone therapy.
No, this was the old version, the old definition of watchful waiting.
Okay.
And, it's just like, well, you're going to die of something else before you die from prostate cancer. So there's nothing really to do. And, it's just kind of, I think men felt kind of depressed about the fact that their cancer wasn't really being treated, or didn't, they, couldn't look to being cured of their cancer.
And that's a problem with all cancer patients. In a sense, there's cancer recovery. Do we ever say that somebody's cured of cancer in any cancer?
Well, people, true, recurrence can come after 25 years. It's true.
Okay. Dr. Metzger, I see you're lit up here on our
No,
board.
I was just going to say, with Arteria AI, we can eliminate almost 70% of the guys that need radiation or need the hormone treatment if they're going to have radiation. And with the development of newer AI things, I think not everyone is that we used to think had to have Lupron and all that stuff are going to need it. And second, some of the studies, especially a guy at Cedars-Sinai here in Los Angeles, Friedman or something like that, where they're taking a lot of vacation time from the hormone treatment. And I'm sure that the men's quality of life is much better if you can take a time off. With Regulolix, the newer oral antagonist, it gets your hormone level back so much quicker, and the guys report a much higher satisfaction with their treatment if they, one, can have a vacation, and two, get their hormone symptoms back. So things are changing.
Yeah, I really can see that with AI. I've been on a couple of talks looking at AI's evaluation of different biomarkers, and going back historically to look at mammograms and being able to now predict which ones might eventually develop breast cancer that couldn't be detected by the human eye. it is an exciting time, I agree.
Yeah, it sure is.
Well, thank you, Doctor. I'm going to open up the questions here. I don't see anything in my chat. Does anyone else have a question for Professor Hamilton tonight? Well, I want to thank you all for attending, and I want to thank you, Professor Hamilton, for
Okay,
presenting the study. And we
okay,
hope
my
to see you
pleasure.
back with a completely different study with all this new stuff
Yes,
and see the difference that so much of the new stuff is made. Folks,
okay,
be sure to check us out in about a week. This should be posted on our website at prostateforum.org/presentations. You'll have a chance to watch this again. In the meantime, have a great Thursday evening. We look forward to seeing you again at our support group meetings and future.
Quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends.